Thank you all for coming. Thank you to ASCI and Professor Subodh for hosting this. It's a real pleasure to come to this campus. Both the authors are from Bangalore, so we traveled here for this special occasion. And what we hope to do in this event is not just focus on the book, but use the book as a kind of a lightning rod for many ideas that may come from different places. In fact, that is the intention in writing the book. The book is very bravely a set of solutions for healthcare, but we know that we don't have all the solutions. There might be better ideas coming from different places, and we want to hear those ideas, whether it is from senior persons working in the healthcare field for many decades, or whether it is fresh students who might have new ideas. So with that, I will start with a preamble presentation for 10 to 15 minutes, and I'll hand over to the moderator for the panel discussion, my co-author Srivathsan, Aparajithan. So if I can have the next slide, or do I have a clicker? So this is a multi-city event. You can go to the next slide. So as I said, our intention is to spread the conversation, to get more people involved in this conversation. And we have been quite successful in the first event in Bangalore. We got a large audience, very enthusiastic participation. And I suspect some of it is because of very deep dissatisfaction with how healthcare is. But there's a larger picture. I mean, apart from the fact that we in the middle class and the upper middle classes are deeply dissatisfied for a set of reasons, the fact is that a majority of Indians don't get healthcare at all. So they are dissatisfied because they don't get healthcare, not because healthcare is bad. So I think we really want to speak about that need as part of the overall picture about how we can bring about good quality healthcare in the country. So I think everyone knows the definition of universal healthcare. The important thing here is that accessing universal healthcare should not cause financial strain. That's the important thing, right? So people sell their land, people sell their houses, people sell ancestral property, jewelry to get healthcare. That's not universal health coverage. Universal health coverage, everybody gets healthcare without those kinds of financial stresses. Okay, I won't go through this slide. It basically compares India and Canada. I just chose Canada as a model country which is set up as an example for universal health coverage, but there is really no best example. All countries have problems. Canada is far ahead of India, obviously, and on these metrics you can easily see that we lag behind Canada in many of the outcome metrics. Interestingly, we are in the rank of between 130 and 140 among all countries in the world, out of the 195 countries in the world that are ranked on healthcare, on many of the healthcare matrices. So we are somewhere near Sudan and the sub-Saharan countries and Hungary and Kazakhstan and things like that. We are nowhere near where we should be. So the question is, can we afford healthcare? And that question can be asked in many ways. One way to look at it is, what is our GDP per capita, right? So people often say that we should spend so much of our total GDP on healthcare. I don't think that is a meaningful number. The number should really be what percentage of GDP per capita we should be spending on healthcare. And this shows the figures of GDP per capita in Canada and India. And the hip replacement price in India, this is obtained from the Ayushman Bharat scheme, is about $1,500. And in Canada, in a private sector, Canada has UHC, but they also have private hip replacement that costs about $17,800. But you see, for Canada, it's only 3x their GDP, their health spend per capita. For India, it's about 20 times our per capita health spend. So clearly, we are underspending, even assuming PPP and all those things, we are underspending on healthcare. And as a result, some 10 crore Indians, and this is Niti Aayog, are pushed into poverty every year because of healthcare. And this 10 crore is not obviously represented in this room. I mean, people in this room, most of us can afford healthcare. We do have medical insurance. This is the 10 crore that we need to be worried about. So this is about 282-page book. It has a set of tables at the end, and for students that those tables might especially be useful. We didn't just present numbers, we commented on the numbers, so there are some interesting comments we have made. You may disagree with some of them, but we would like to know. That we just put it out there. This is what we feel, and we would really like to have discussion and debate around those comments. But we have distilled the contents of the book into 7 principles, right? There could be more. I mean, this is just a summary of the book. And one obvious thing is that primary healthcare is broken, right? No country in the world, I mean, I would say no country in the world, even the countries which have UHC, like Canada and UK even, although they have primary healthcare, their primary healthcare systems are under enormous strain, both because they are not finding the doctors to staff primary healthcare because it is not an attractive the career option, and also because they are strained by the volumes of patients they have to see. Right? So this is stressing out primary healthcare in every country in the world, including the ones where healthcare is in great shape. So for India now to establish a meaningful, well-running, well-oiled healthcare system, we can't just copy what has been done in the UK and the US and say, okay, we're going to try and do primary healthcare this way. We have to do something very different. And what we have said in the book is, let primary healthcare be largely driven by community health workers, but have more of comprehensive health centers where you can deliver much more healthcare in a center because it is also delivering a level of secondary care, the specialist care. So our concept is that even our primary healthcare physician should be called comprehensivists, and we should invert the hierarchy. Right now the specialist at the top of the hierarchy, we are saying let the comprehensivist be at the top of the hierarchy, controlling the process of healthcare, that is determining when somebody needs specialist care, following them up after specialist care is given, deciding which specialist they should go to, all that should be determined by the comprehensivist. So we are putting more power in the hands of the comprehensivist, which means the comprehensivist has to be better trained. The current MBBS training is not sufficient to produce comprehensivists. So you need an MBBS plus doctor or an MD internal medicine doctor delivering comprehensive healthcare. When we do that, we can increase salaries for these people, make that profession attractive. People would be proudly say, I'm a comprehensivist, just as they are currently proudly saying, I'm a cardiac electrophysiologist, right? So we need comprehensivists also to be proud of their profession, earn a decent salary, and therefore wanting to go to places where those kinds of jobs are available. Second is, we run healthcare, at least in the front lines, like a cottage industry. So you have a doctor, you have an ante-room, you have a boy sitting outside, things like that. It's really run in a very ancient manner. We need to do more automation. We need to run it like an industrial process, right? And that will require, for example, universal implementation of electronic medical records. And we need to take medicine from it is practiced the way it was practiced in the late 19th century and bring it into the late 18th century and 19th century and bring it into the 21st century. Payment model should promote appropriate consumption. So you have the Ayushman Bharat scheme, right? So the Ayushman Bharat scheme is very good because it is plugging a gap. But it's not the best way to deliver healthcare because it is supply driven. It is creating more traction on the supply side without controlling the quality of the supply and the appropriateness of supply. It is rife with corruption and unethical practices where hospitals fake patient encounters, and I was reading the newspaper the other day that there is one mobile number attached to like 75,000 patients on the system. It's really not working, and we believe that such a supply-led system is not ideal because, as we say, when you increase supply and the demand is in the hands of the supplier will increase the demand in order to match the supply, and therefore supply will have to go up again, and therefore the supply will increase demand further, so you have a vicious spiral setup on which healthcare costs keep on going up. There is no cap on it. The other thing is there is enormous amount of waste in healthcare. We don't have numbers for India, but the numbers in the US suggest that there's about 50% of healthcare expenditure in that country is wasted, meaning that it is not producing any benefit for the patient. And this can actually be having adverse effects as well. For example, if you have give an antibiotic in a community, when an antibiotic is not warranted, you actually cause antimicrobial resistance, which leads to additional costs which are remaining with the community for a long term. And those costs, if you factor that in, it's easily at least 15% of costs are wasted. This means that if you want to increase spending on healthcare like UHC, you first have to plug that wasteful healthcare before you start increasing spending. Otherwise, every rupee spent, 15 IMS is going towards wasteful healthcare. So I don't think in an ideal world the for-profit delivery of healthcare is appropriate. But the fact is that we already have a for-profit system, and our government systems have not on their own shown the ability to step up and produce an equivalent level of care. So we really need to hybridize these two systems. The government system and the not-for-profit sector has the ability to deliver care that is compassionate, that is relevant and appropriate. And the for-profit system has the ability to deliver care that is efficient and delivered high quality. So I think we need to hybridize this. We have proposed a model of managed competition in the book, where we can actually productively hybridize for-profit and non-for-profit healthcare. So we can't tinker with the system at one end and then expect that the intervention will be effective. We actually need to take a whole systems approach. For example, if a hospital decides that for efficiency reasons or to reduce costs, they are going to discharge their patients one day early, they must take into they must factor the possibility that the patient will be readmitted because the wound is not healed, or there is not sufficient rest given, or there is not sufficient post-surgical care. So I think that cost has to be factored in. So there's no point tinkering with pieces of healthcare one at a time and hoping that you are going to benefit the system. You might actually cause greater harm by that kind of tinkering. So, and finally, I think we let the government off the hook. We are almost, the government has said we are not going to deliver healthcare, we're just going to put this schemes like Ayushman Bharat, etc. We need the government. It is wrong to say that the government cannot do a good job. We have almost, this is a very fatalistic assumption that government can't do anything good. The government can and should, and we as citizens have a responsibility to get the government to understand it is their job to provide high quality universal healthcare to all Indians, right? And there is no other way out of it. You cannot have the private system orchestrating healthcare. It has to be the government, not-for-profit sector. So there are other things I'm not going to cover now. I'm going to move to the